My name is Talu Old Dog Bureau, and today I'll be presenting on postoperative sore throat education and treatment. I want to thank you in advance for taking the time to hear my presentation today, and I hope you enjoy. The learning goals of this presentation is to analyze the incidence and relevance of postoperative sore throat, identify risk factors, appraise treatment modalities, and formulate an anesthetic plan to prevent postoperative sore throat. A common question you may have is, what is the importance and relevance of postoperative sore throat? Postoperative sore throat is the second most common complaint after general anesthesia, trailing only postoperative nausea and vomiting. It's an aseptic inflammatory process triggered by laryngoscopy, endotracheal tube cuff irritation, and intubation and extubation trauma. 30 to 70% of people experience postoperative sore throat and hoarseness after tracheal intubations. Symptoms include dysphonia, dysphagia, persistent throat pain, hoarseness, and pharyngeal dryness, which can lead to discomfort, exacerbation of patients' trouble eating and speaking, diminishing postoperative comfort, and lengthening the patient's hospital stay. Similar to postoperative nausea and vomiting, postoperative sore throat has associated risk factors that can aid in identification and treatment preoperatively. Unfortunately, a formal tool has not been developed for postoperative sore throat. As a result, I have developed a tool to aid in the identification of these risk factors, which include female sex, young age, history of smoking or lung disease, neck surgery, difficult intubation, duration of the anesthetic, and administration of succinylcholine. The presence of 3 or more risk factors requires treatment with 2 pharmacological agents as well as non-pharmacological modalities. Based on the airway device, the location of the injury will differ. For example, with an endotracheal tube, the patient will experience injury to the larynx, trachea, and any part of the pharynx. With an LMA, they'll experience injury to the supraglottic pharyngeal mucosa. And with the face mask, with an oral airway, it results in injury to the oral pharynx. There are a number of non-pharmacological modalities that one can use to help limit the incidence of postoperative sore throat. Among them is decreasing the endotracheal tube size, lubricating the tube, being gentle while instrumenting the airway, gentle oral suctioning, decrease the cuff pressure, and extubating post-cuff deflation. NMDA receptor antagonist has been shown to be effective in treatment and prevention of postoperative sore throat. NMDA receptor antagonists do this by preventing glutamate from activating the NMDA receptors and decreases the presynaptic release of glutamate. These receptors are found in the peripheral nerves that transmit nociception. As a result, patients will receive an anti-nociceptive and anti-inflammatory effect with the use. These medications suppress neutrophil production of inflammatory mediators and also have an analgesic effect attributed to direct inhibition of cytokines. The innate repair receptor is key in diminishing tissue damage and inflammation. Within the class of NMDA receptor antagonists is ketamine. Studies show that ketamine prevents airway irritation and results in peripheral analgesia without systemic effects. It can be given gargled or nebulized. Nebulized ketamine is better tolerated. It eliminates the unpleasant aftertaste while requiring a significantly smaller volume. Low-dose ketamine is considered 40 to 50 milligrams, while high dose is considered 100 milligrams. Studies have shown that ketamine gargled at 100 milligrams considerably reduced postoperative sore throat compared to 50 milligrams, with an absence of systemic effects. Another NMDA receptor antagonist is magnesium. Magnesium via nebulizer can be administered consistently from patient to patient, covering the entire supraglottic region where instrumentation and mucosal damage occur. After a mucosal injury or instrument-induced stretching of the pharyngeal muscles, excitatory amino acids, notably glutamate and inflammatory mediators, are released. Prior occupancy of NMDA receptors inhibits glutamate-mediated central sensitivity and prevents the sensation of postoperative sore throat. Studies show that postoperative sore throat can be mitigated for 24 hours by the prophylactic use of nebulized magnesium. 5 ml nebulization containing 250 milligrams of magnesium. Another medication that is a part of the NMDA receptor antagonist class is tramadol. Tramadol is a codeine analog that functions as a mu-opioid receptor agonist and an NMDA receptor antagonist. It inhibits monoamine reuptake and contains local anesthetic properties. It behaves like local anesthetics by inhibiting voltage-dependent potassium and sodium channels. It can be delivered via 2 routes, with a 2 mg per kilogram gargle, which has been shown to attenuate postoperative sore throat symptoms for up to 24 hours after surgery without causing any systemic adverse effects, or a 1 mg per kilo nebulization, which has been shown to substantially minimize the occurrence of postoperative sore throat. Dexamethasone has also been shown to have efficacy in treating postoperative sore throat. Prophylactic administration of steroids was observed to minimize the incidence of sore throat and cough during recovery. It modulates the inflammatory process generated by tissue injury. The anti-inflammatory mechanism inhibits leukocyte migration to the inflammation site and cytokine release. It suppresses interleukin-2 by inhibiting arachidonic acid metabolism and leukotriene B4 synthesis, thereby modifying the inflammatory process. By itself or in conjunction with 1.5 mg per kilogram of lidocaine, IV dexamethasone significantly decreased the incidence of postoperative sore throat. Lidocaine use alone, however, did not see a statistically significant decrease in the occurrence of postoperative sore throat. Dexamethasone is more efficient when combined with other treatments than when used alone. Dexamethasone decreases the incidence of postoperative sore throat in the first 6 hours following extubation. However, it does not affect the incidence of sore throat 24 hours later, but it does diminish the severity of sore throat 24 hours after extubation. It can be given through gargle or IV. The dose is 0.1 to 0.2 milligrams per kilogram IV or a 0.05% gargle. Combined use of a dexamethasone gargle and IV injection did not have a greater postoperative sore throat preventative impact than using either technique alone. Just some quick take-home points before I complete the presentation. Patients ranked postoperative sore throat among the most undesirable postoperative sequelae, although it usually subsides independently. Reducing the intensity and occurrence of postoperative sore throat should shorten hospital stays, reduce healthcare costs, and increase patient satisfaction. Treatment of this phenomenon has been lacking and variable. Identification of risk factors during preoperative evaluation will aid in early treatment. Preventative, proactive treatment preoperatively rather than reactive treatment postoperatively will aid in reducing the incidence of postoperative sore throat. Studies show NMDA antagonists and corticosteroids are effective pharmacological treatments to reduce the incidence and severity of postoperative sore throat without systemic side effects. I want to thank you again for taking the time to listen to my presentation on postoperative sore throat. I hope this presentation provided you with new knowledge or reinforced your already existing knowledge. Thank you again, and have a good day.